Well, moving on with the main Congress, the next session, I cordially invite the chairpersons, Dr. Kumar Mendes, Consultant Family Physician, and Dr. Spool Oganathan, Senior General Practitioner, United Kingdom, on stage, please. The next session is plenary, Fostering Family Medicine Partnerships in Primary Care, Cost-Effective Care en route to Universal Health Coverage, by Professor Kay Mohanna.
Welcome to the first plenary of the day. The topic is Fostering Family Medicine Partnerships in Primary Care, Cost-Effective Care towards Universal Health Coverage, by Professor Kay Mohanna. Professor Kay Mohanna is a current Professor of Value-Based Healthcare Education in University of Worcester. She is also the MB-CHB Program Director and Admission Tutor at 3 Counties Medical School, University of Worcester, and a partner and a trainer in Darwin Medical Practice, Lichfield. She obtained her doctorate in education from the Institute of Education, University College of London in 2016. She held many local and international positions, including the Director of Postgraduate Medicine at Keele University School of Medicine, the Co-Director of Keele Clinical Leadership Academy, Associate Dean of West Midfields Deanery. She is a Fellow of College of GPs of Sri Lanka, College of Physicians and Surgeons of Bangladesh, and a member of the College of Family Medicine, Pakistan. Professor Kay is the current chair of Medical Education Committee Doctors Worldwide and Sri Lanka University of Worcester Family Medicine Fellowships lead in 2016. She's having many scientific publications and citations under her name. She's particularly interested in system building, and she has published many books on the development of practical skills among doctors. So I invite Professor Kay Mohanna for the presentation.
Thank you very much, dear chairs. Good morning, everybody. It's such a delight to be here and to see you all. I hope you can see me over the top of this lectern, and maybe stand to the one side, it might be better. I'm a bit short. It's a very great honour and privilege, and thank you to everybody for inviting me here this morning. I'm going to say a few words about family medicine partnerships in primary care, really to precipitate a discussion. So I don't think I have anything new or unusual to share with you, because you know this topic as well as I do, because as family physicians, partnerships are at the heart of what we do. So really my job today is just to provoke a few areas to think about, rather than impart any new information. So many thanks to the organising committee for the invitation, and to Madam President for her gracious presence and invitation this morning, my very dear friend going back some years. So I'm going to talk about partnership in 4 different ways. Firstly, partnership between colleagues. I am extremely fortunate to work in a large group practice. So in the United Kingdom, it's very common for people to work in partnership. And there are a total of 7 of us who are partners, with 6 employed doctors and currently 7 trainees. And then we have a variety of medically allied professionals. And I'll tell you a little bit about the partnership in which we work. Then I'm going to talk about the importance of partnerships between institutions. A little bit about the importance of partnerships between nations. And something crucially about partnership with patients. And those are my 4 areas on partnerships this morning. So, quick definition to remind us all what we're talking about. Cooperation between equals for mutual benefit. And I think it's important to stress that we're talking about collaboration and cooperation between equals. That's the basis of a partnership, like a marriage, like any other form of partnership, that the 2 partners are equal. They come with differences, They come with different strengths, they come with different areas of knowledge or expertise, but they collaborate as equals. And that's important because that implies from the beginning a mutual respect. And partnerships work when they are based on respect and when the partners trust each other. And from that equality flows trust. In the field of values-based medicine that I practice, we talk about a range of values which are defined as motivating factors, things which govern our daily practice, the things that we place value on and have value for us. And two very important values in partnership are respect and trust. And everything I'm going to say about the 4 types of partnership flows from that. So first of all, between colleagues, the Royal College of General Practice recently declared that the partnership model of general practice delivers exceptional benefits for the NHS. And the reason why the college stressed this recently is because actually it's under threat in the UK. The government feels that those pesky GPs are irritating to them, that they're always creating problems, raising questions on behalf of patients, complaining about not enough investment in the NHS. And there is a sense that we have that partners are seen as a problem. And if we were just employees, then they could control us more closely. This is our feeling at the moment. So the college came out and said, no, you're mistaken to complain about partners. Partnership in general practice in the UK is the fundamental building block for a safe and effective primary care. So GP teams that are led by partners can innovate, can tailor the care and the services to their local populations, and offer good value because they hold the risk. Some of you who heard me speak last night will hear me talk about the importance of general practice managing and holding the risk in primary care and not always referring into secondary care, which is under great pressure. So the college came out and said it's offering very good value because it relies on the goodwill of partners to organize care within practice. We are considered to run the business of general practice. It's an unusual setup within the NHS, which, as you know, is federated care, free at the point of service, and run by the government effectively, by the Department of Health. In general practice, we are contracted, we are self-employed, contracted within the NHS, and in the financial speak, we run and take a profit from the business. And that's what the government looks at. They say, oh, you're just like a firm of engineers or a firm of plumbers. You run the business, you take a profit. No. Although we use these words, that profit is ploughed into running the service. It's not taken home. Some, of course, is taken home in salary, but it's there to run the service. And we can take the money from the government and use it to define and develop the service. Everyone else in the practice is technically employed by us, or they might be attached. And attachment means they're salaried from elsewhere, but they're part of our team. So, for example, pharmacists and practice nurses might be attached. And the college pointed out that what the health service wants is a setup where healthcare professionals ensure patients receive the most appropriate care, of course, but the college says that's already happening through the partnership model. So the first model I want to talk about is the partnership. So you can't really read this, but this is a map of the people who work in my practice. In green at the top, there are my partners on the very top line, and I would give thanks to my partners. They're very tolerant of me, very forgiving when I ask for time off to visit my friends in other countries, which I do, and I'm very privileged to do quite often. You need good partnerships who recognize what you bring back to the collaborative from learning abroad. So now I know much more about ophthalmology than I did maybe 45 minutes ago, and I will take that home to my practice. And that's one of the benefits of partnership. In pink, we have the administrative and management side of the practice, including our valuable receptionists who are our first line with our patients. And in the blue, we have the other partnerships of clinical professionals. We have nurses, healthcare assistants, and midwives. We are very fortunate. We have allied attached paramedics and pharmacists as well. So these are the names, and I want to recognize my friends and colleagues in these names, but the point really for today is look how many people are involved in that partnership, not just one-to-one. I mean, I think currently we have 52 people in the practice. And here are some of them. I'm very proud of them. They're smiling at you this morning. On the right, two men kneeling on the floor. They're two of my GP partners. On the back row on the left in the stripy top, that's Helen. She's also my partner. And I think I'm taking the picture. So we have a big practice. These are the numbers of appointments we see. We have nearly coming up to 18,000 patients between us now. But an important point on partnerships, look who does the appointments. 1645 on an average week, just over 1,000 from the doctors, and all the others combined also seeing patients first contact. Secondly, I want to move on to partnerships between institutions. So clearly, institutions in the UK have already started to touch on, we're funded in a certain way, but also we have academic and professional collaborations. And I want to talk about the perspective from my medical school. As I told some of you last night, we're very excited. We're in our first ever year in the medical school. Our students are 10 weeks into their career, just 10 weeks. And I see them like a little seed, which we plant in the soil of the NHS. Our curriculum that we develop has to grow and flourish, and it can only do that in partnership with the Venn diagram on the left, which shows the NHS itself, the source of the clinical training, the taxpayers who fund our medical students out of the tax pot, and higher education institutions, that's the university. So the first partnership in a medical school in our country is the Venn diagram that shows how the NHS, the clinical setting, the funding, and the academic setting come together. But there's another partnership which is got the patients at the centre instead of the students at the centre. The one with the patients at the centre is a partnership between all the healthcare professionals, the members of the public as individual patients and carers, and the students themselves. So the people are in partnership as well as the institutions. And one of the important collaborative values that can come out of institutional partnerships is the one of social accountability. So our medical school knows that it is embedded in the community, partly because it's funded, as you saw, by the taxpayer, but also it's a collaborative partnership of the members of the public with the students and the patients and all of us healthcare professionals. And this is not new. This is an old quote now, 1995. And the WHO is talking about social accountability being a measure of the extent to which medical schools listen to what's needed, provide what they can in training and education, but they respond and negotiate with their community to form a social compact, a contract, if you like, between society and the medical profession. And to me, this is crucial because we sit within a society where we are all in partnership with each other in one or other ways. And medical schools these days no more sit on top of the ivory tower giving out our pearls of wisdom. We are embedded in society, listening and responding, being flexible and adaptable to what our patients need. And this arises only through those partnerships. Okay, what about partnerships between nations? I want to very briefly tell you a little bit about the University of Worcester PGIM post-MD fellowships. many of you are much more knowledgeable on this than I am, and it has been my privilege to co-lead this with Professor Antoinette. And this shows how you can form partnerships across the seas. Of course, in these days, we are very familiar now with Zoom meetings, Microsoft Teams meetings. When we set this up, it wasn't exactly the days when you had to write with a pen and paper, but we didn't have so much of technology that we understand now through the pandemic. So I do remember phoning Dr. Preeti on the telephone. This was the most technology we had in those days. But we set up this partnership, and it has worked because of people's goodwill and enthusiasm and the co-creation of a respectful bilateral relationship. So this is one picture of the new medical school building, one of the new medical school buildings. Actually, this is called Charles Hastings Building, and Charles Hastings was the founder of the British Medical Association, the BMA. So actually, even though we are very brand new and we only have 10-week-old medical students, we have a long history in the medical setup, and we have some connection. I can't take much credit. I wasn't really around in 1832, but Charles Hastings set up the BMA. So far, we have, I think, 14 completed. We have 2 just about to start. Yesterday, I had an email from one of your colleagues who's just arrived in the UK, the latest of the fellows. And these fellowships have brought great benefits on both sides. So research projects have been done. I remember when Madam President was with me and she did her project on the carer burden, looking after patients with dementia. So Dr. Milroy, Dr. Pradeep, Dr. Harsha, and Dr. Malkanti did this wonderful project where they went to interview carers living with a family medicine member who had dementia. And that was a form of partnership. They took their family medicine values into a new country, and they had interviews with carers. And I have one wife who still talks about when you went to see her to talk about her husband. Sadly, her husband is no more, but she remembers you. And these are strong bonds that bind us as family physicians all around the world. And there were all sorts of others, projects. So I could tell you all about them, but sadly we don't have enough time, but I'm very happy to talk with you over coffee. Partnerships between institutions. And finally, I want to come to what is probably closest to the most strongly held value all of us share, and that's the importance of partnerships with patients. Clearly, we understand that we are servants in the good of patient care, but we are also partners in the mutuality that I described at the beginning. The mutuality means equal respect, trust in each other, but equal respect meaning I value the patient's lived experience as true for them. They know how it is to be a patient. I have knowledge out of books, and now at this stage I have knowledge that patients have taught me over the past many years. But I respect their lived experience, and that's the basis of partnership. In the UK, we have registered lists. Some of my patients are now grandmothers, and I saw them when they were mothers, and some I saw when they were young women. So I've seen my patients grow with me. I've seen them with minor illnesses, with major life events, and the continuum of family medicine is played out through the partnership with patients. So we strive for continuity of care, which we get automatically in some ways by the registered list, but through patient choice. They come back and come back. They come back when they're worried that they might be ill, and they come back when they are ill. So those longitudinal relationships built on partnerships with patients is the founding principle of family medicine. But also I just want to mention in our practice, we have a patient participation group, and I know Dr. Pulu also has such an organization. Patient participation groups are truly an example of collaborative practice, where we have patients who come together and advise us and guide us. You can see that the last meeting was held in October. Sometimes they grumble, sometimes they complain, that's natural. Sometimes they compliment and praise us. But all the time, they tell us things we can learn about to improve our service. So that partnership is crucial. If we are to develop what I described earlier, talking about the medical school as that social compact, that form of a contract that makes us responsive to the needs of our particular community. So Dr. Pullu and I, we work in very different types of community, different levels of maybe socioeconomic exposure. So we have built different practices. And Dr. Pullu is loved by his patients because of the way he understands some of the difficulties that they work and live with. True partnership. So the patient engagement group, patient participation group, you can see me describing here how we ensure we have the patient perspective, how we ensure that we respond to their concerns. The COVID pandemic is a good example. We all, in some ways, stopped being doctors and became members of society, subject to the same constraints, the same requirement to wear masks and PPE, the same having to stay at home that our patients suffered. And actually, in some ways, it brought us together. And then, of course, we spent many Saturdays and Sundays giving vaccines, so we're all in together. But they contribute to decision-making. So we, you couldn't see it behind the rows of smiling faces, but we were sitting outside of our new medical building. We took their advice right from the stage where we were with the architects working out how to build it. They were involved with the new premises. They also run some services, some reading groups, some patient education groups, and some volunteering organization and support groups. So, for example, just one quick example, they run transport for patients to hospital. We're in a very rural area. Public transport is not always so good, and patients don't always have a car. So we have a volunteer group that patients can contact for a free lift to the hospital for an outpatient. Maybe somebody's attending regularly for chemo, and they will make a bond, another form of partnership, with the volunteer who's their driver. Patient engagement groups, I would commend them to you to think about. So those are the 4 areas of partnership I want to discuss. Very happy to take any questions or comments.
Thank you, Professor Kay. Any questions now? You have the option of asking questions.
Thank you so much, Madam, for enlightening us about the partnership. I'm Dr. Farhat, Registrar in Family Medicine. Madam, now RACGP recognized the MRCGP International as a specialist pathway to practice there. So in UK, Madam, what are the barriers to recognize us, even though we have the MD and the MRCGP International as well, to work there with the paid training? What is the barriers there in UK?
That's a very good question. It's a source of a lot of frustration. The barriers mostly are at the level of government. So the legislation requires independent GPs in the UK to go through UK training. And they don't recognise international training as the same thing. So until the law is changed, that can't happen. And the reason why they don't recognise it is because epidemiologically, the exam that we run in South Asia is based on South Asian demographics. So, for example, I know more now through my partnership with you guys, but I know very little about dengue, for example. We don't see it. We don't see cerebral malaria. We don't see so much TB. There are a lot of infectious diseases that are not common. So our exam in the UK is not focused on these things. But it's really important that GPs in South Asia have knowledge in these areas. So the exam epidemiologically is different. Secondly, a lot of what I've described this morning about the infrastructure of how we run general practice, and as Dr. Pullu actually just reminded me, we have something called primary care networks, very important partnerships within localities. We test our juniors on their knowledge of the NHS, and that isn't in your exam at all. So those are just 2 examples. where the government says this exam is not equivalent. And then what happens is the regulatory body, the General Medical Council, doesn't recognize that training for that reason. If the law was changed, the GMC might start to recognize. You can use MRC GP International as part of a portfolio of evidence, but they don't accept the exam just on its own, not like Australia have started to do. It's a work in progress. A lot of people trying to push, but we don't have a lot of influence, and the government, it has its mind on other things. I think you have similar problems sometimes. But thank you for the question.
Just want to make a comment about this GP's qualified postgraduate qualification, that's MD, family medicine, how to come and work in United Kingdom. My current trainee, Dr. Achala, just got the full registration at the GMC on the recommendation from me, because he worked with me for 6 months and he applied for it. And there were a lot of correspondence between GMC and Dr. Achala and myself. After so much of scrutiny, they gave him a full registration. That means he can work in the hospitals now. But the next step, to get the performance list, involved in the performance list, they have started a scheme. If you work in a practice, they have got IMG, International Medical Graduates Training Program. He has to apply, and he has 6 months he had to work with the practice. And at the time, they are paying also, £4,000 they are paying during the training time. Then he can work as an independent GP in United Kingdom. So the door is open now. So yeah, it's a process. So if you go through that.
I think time is catching up. Thank you very much, Professor Kay, for the lecture and the clarifications.
Thank you very much, Professor Kay Mohanna, and I could invite the chairperson to give away the token of appreciation to our presenter, to Professor Kay Mohanna. Please come forward, sir. Thank you very much.